My presentation is on velopharyngeal insufficiency, VPI, in children. Velopharyngeal insufficiency occurs due to the improper closing of the velopharyngeal sphincter because of an anatomic dysfunction of the soft palate or of the lateral or posterior wall of the pharynx. The soft palate does not close tightly against the back of the throat, which leads to issues with speech. The most common cause of VPI is cleft lip and/or palate. Many researchers have studied the assessment of VPI in children, as well as surgical treatments. Once a diagnosis of VPI is determined, most undergo surgical procedures. Even after surgery, though, many still have resulting speech problems. This presentation discusses those potential speech issues that may arise with this type of patient. So VPI is a resonance disorder. It's associated with the physiological dysfunction in the coordinated movements of the velum, or the soft palate, and the posterior and lateral pharyngeal walls. Cleft lip and palate, both before and after repair, are the most common causes of VPI. Studies have reported that between 20 and 50% of those with cleft lip and palate will exhibit VPI. There are some other causes of VPI in children. Adenectomies, so the removal of the adenoids, the lymphoid tissue in the back of the nose. This can occasionally result in VPI. It creates more space between the soft palate and the back of the throat there where the adenoids used to be. This VPI that occurs after an adenectomy is usually temporary and improves after a few weeks. It rarely persists long term. There are some disorders associated with genetic syndromes that can cause VPI. So neurofibromatosis, Kabuki syndrome, 22q11.2 deletion syndrome, palatal tumors, and congenital VPI not associated with any of the above. So some literature on the evaluation and diagnosis of VPI. Currently, a combination of video nasopharyngoscopy and multiplanar video fluoroscopy is the procedure of choice for assessing velopharyngeal function during speech. VMP can provide images of the entire vocal tract in motion during speech production, and MPVF provides X-ray images of the vocal tract during this same function. The assessments mainly used to evaluate VPI are either invasive, so the nasoendoscopy, or imposed radiation exposure, so the video fluoroscopy, which has been limited in children. So another study found that dynamic MRI is a non-invasive, rapid, and repeatable method for evaluation of VPI. It can be used for assessing VPI without any sedation or radiation exposure. So that can be a really great alternative. As far as treatment, typically VPI is treated with surgery. Specifically, pharyngeal flap surgery has been a standard treatment approach for years. After surgical correction, 20 to 34% of patients do not acquire a desirable amount of velopharyngeal competence due to limited mobility of the pharyngeal flap. A removable palatal lift appliance, also known as an obturator, in conjunction with speech therapy is a viable treatment option for such patients as it's economical, easy to fabricate, and easy to use. Another study, which I found interesting, found that fat injections improved voice resonance and reduced nasal air escape in all treated cases, and can be a promising alternative to major procedures, such as velopharyngoplasties, for the treatment of mild to moderate VPI. So this wouldn't be for those more severe cases. So what are the clinical implications of this? How does this apply to SLPs? So as we know, sound waves are generated by activity of the vocal folds and air going upstream through, and then it's intensified through these three resonating chambers: the pharynx, the oral cavity, and the nasal cavity. The soft palate, also known as the velum, and the pharynx differentially function as a muscular sphincter during sucking, swallowing, and speech. So the velum elevates, as you can see in this picture on the right, where it says velum raised. It elevates and retracts against the stationary posterior pharyngeal wall, and the lateral pharyngeal walls merge medially to compress the displaced velum to achieve a tight seal. So in individuals with VPI, they are not getting that tight seal there, that complete closure. So in the English language, the sounds of and are normally articulated with associated nasal airflow and resonation or nasality, because during their speech production, the velopharyngeal valve remains open. So in individuals with VPI, you'll see that there are some resulting speech abnormalities that can occur. So there are some abnormal speech characteristics that can arise with a child with VPI. Hypernasality is one of those. This is speech that sounds overall nasal, as if the person is talking through his or her nose. It occurs when there's too much sound resonating in the nasal cavity during speech. It's particularly perceptible on vowels, since these sounds are voiced and relatively long in duration. It can also affect the production of voiced oral consonants. The severity depends on the size of the opening, the etiology, and even articulation. Nasal air emission is another abnormal speech characteristic. This occurs when there is audible emission of the airstream through the nasal cavity during consonant production. This occurs during the production of those pressure-sensitive sounds, so plosives, fricatives, and affricates. And nasal grimace often accompanies this nasal air emission. Weak or omitted consonants are another abnormal speech characteristic. Nasal air emission reduces intraoral breath pressure, causing consonants to become weak in pressure or even omitted. The greater the nasal air emission is, the weaker the consonants are. So children with VPI can also develop these compensatory articulation patterns secondary to their VPI. So if VPI causes inadequate oral pressure for oral consonants, the child may develop compensatory articulation productions. These productions are typically made in the pharynx where there is airflow. Compensatory productions are easiest to correct after surgical correction. Once surgery is done to correct the abnormal structure, speech therapy is then necessary to correct the abnormal function. So one compensatory articulation pattern you may see is a glottal stop. So this is produced with forceful adduction of the vocal folds and the buildup of air pressure under the glottis. The ventricular folds, also known as the false vocal folds, often approximate with the forceful closure of the true vocal folds. And as we've learned in class, this can be really bad when those false vocal folds are closing as well. So in the glottal stop, the vocal folds are suddenly opened and then release the air pressure to produce a grunt type sound. You may also see pharyngeal plosive or stop, and this is produced when the base of the tongue moves backward to articulate against the posterior pharyngeal wall, and then the dorsum of the tongue is concave and low in the oral cavity. And this is usually substituted for those velars, so k and g. And this is due to difficulty producing this phoneme. There's often a longer duration than usual between the consonant and the vowel. Another compensatory articulation pattern is pharyngeal fricative. This is produced when the tongue is retracted, so the base of the tongue approximates but doesn't completely touch the pharyngeal wall. A friction sound occurs as the air pressure is forced between the small opening between the base of the tongue and the pharyngeal wall. The velopharyngeal port remains open, resulting in nasal air emission. Some more of these patterns, you can also have a pharyngeal affricate. So this is produced as a combination of the pharyngeal plosive and the pharyngeal fricative. And as with the pharyngeal fricative, there is nasal air emission as well. There can also be a velar fricative pattern. So this is produced with the back of the tongue in the same position as for the production of a y sound. When friction occurs as air is forced through that small opening between the back of the tongue and the velum. Another compensatory pattern is posterior nasal fricative. So this is produced with the back of the tongue articulating against the velum as for the production of Air pressure builds in the pharynx and blows the velopharyngeal valve open. This results in a loud friction sound, which is similar to a nasal rustle due to turbulence. And there's also just generalized backing. So there's an attempt to articulate where there's maximum air pressure. So before the air pressure is lost through that velopharyngeal port and going out through the nose. So the phonemes are produced with the back of the tongue against the velum or against the posterior pharyngeal wall. It's important to note that all abnormal speech characteristics and compensatory articulation patterns are considerably variable across individuals. We know that in our field, no one case is the same, no one individual is the same, and this just applies as well. In children with VPI, they may have one of those abnormal speech characteristics. They may have a couple different of those different articulation patterns, but you really just have to take it case by case and not assume anything. While this presentation mainly focused on the speech aspect, I did want to note that there can be nasal regurgitation in very acute cases of VPI. I just thought this was important to note as we do also deal with swallowing, and it's something to be aware of. And VPI can also affect social communication. So individuals with VPI may be socially devalued by others because of the character of their speech. And in turn, they may respond to the negative reaction of listeners by limiting their opportunities to communicate. They may not want to speak as much if they see that people don't respond well to their speech. So those individuals with VPI may experience limitations in communication that extend beyond the primary physical dysfunction of the velopharyngeal system. So I think that's really important to note, that there may be some structural issues and they may have surgery and they may have fixed that, but there are social implications. So I think it's really important to keep in mind. Speech therapy cannot change hypernasality or nasal emission due to abnormal structure. I think that's really important to note as well, even if there's only a small gap. Also, speech therapy is usually not effective in improving nasality due to abnormal physiology. When there's VPI, surgery or a prosthetic device is required for correction. So you really need that surgery to be able to fix that. We can't change the structure of something. So it's important to keep in mind that ASHA code of ethics. Do what's ethical. If you can't provide a service to somebody and it help them, then you shouldn't be providing the service. But therapy is effective and appropriate if the individual demonstrates any following. Those compensatory articulation productions that are secondary to VPI that cause nasal emission, that is something that we can work on and that we can help them with. And misarticulations that cause nasal air emission or hypernasality, that's phoneme specific, we could work on that as well. Also, hypernasality or nasal emission following surgical correction. So this is because changing structure does not change the function. So the child was doing one thing for so long, now they have the surgery, they need to learn how to now use their new structure. So they need to learn how to use the corrected velopharyngeal valve, and auditory feedback is a great way to do that. In summary, VPI is a prominent issue, specifically in children with cleft lip and/or palate. While much research is being conducted on the evaluation and treatment of VPI, there are still a plethora of possible resulting speech complications from VPI, even post-surgery. As SLPs, it's important to be aware of those abnormal speech characteristics, compensatory articulation patterns, and social communication problems associated with VPI. While it's unethical to treat someone who would not benefit from services, there are circumstances in which treatment is a viable and ethical option, and it's important to be knowledgeable about those specific situations.